Thank you for joining us for today's American Ambulance Association webinar. The webinar is being recorded. The on-demand archive will be posted to the AAA website within the next 48 hours of the live session and will be included in the next AAA Member Digest e-newsletter. A link to the slides for today's session will be posted into the chat shortly and was included in the reminder email. To ask questions, please use the Q&A function, double dialogue bubble button. The chat will be disabled for participants. Cree, the floor is yours.
Good afternoon, guys. I apologize in advance for the cold that my two little monsters shared with me from daycare. So I'm excited to be here today to talk to you guys. I'm going to get my screen shared. And without further ado, we will start talking about human trafficking in children and adolescents. So as noted, my name is Cree Kachelski. I am an assistant professor of pediatric emergency medicine and child abuse pediatrics. I work over at the Mayo Clinic in Rochester, Minnesota. And one of my big areas that I really take heart in and a special interest in is the care of children and adolescents who've been trafficked, whether it's labor trafficking or sex trafficking. So I'm excited to talk to you a little bit more about human trafficking in this population. I have no financial disclosures. The objectives that we're going to discuss today include going through all the different terminology and being able to define what human trafficking is, understanding there's really no stereotype for this trafficking victim, identifying the risk factors for human trafficking, knowing the medical concerns that come when we care for or identify these victims, and getting familiar with some of the resources. So the plan for the next 60 minutes or so, how we're going to meet these objectives, include discussing all of the definitions of terminology, going through the misinformation that's currently out there about trafficked victims, going through the risk factors for being trafficked, going through the medical concerns, like I said, when we identify these victims, and ending with some resources. So let's start with some definitions and terminology. So this is the definition of trafficking. It's the recruitment, transportation, transfer, harboring, or receipt of a person by any means of threat, force, coercion, abduction, fraud, deception, abuse of power, or giving or receiving payments or benefits in order to have control over another person. So you can see it's a very large definition. Within this definition, there's two different forms of trafficking. There's labor trafficking, which I'm not going to touch on this lecture, and then human sex trafficking, also known as human trafficking. When we start saying human trafficking when it comes to children, there's other terminologies that are used. So somebody who's under the age of 18, who's engaging in a commercial sexual act, which human trafficking is considered. These are all of the different acts that would be part of that definition. So trading sexual activity for anything of monetary value, exploitation or prostitution, the sex travel tourism industry or streetwalkers, forced marriage, the mail order brides, production of child pornography, which is now known as child sexual abuse materials or CSAM, any type of solicitation online for sexual abuse, performing in sexual venues such as strip clubs or dancing. With children, what's different in this population under 18, you do not need force, deception, or any other means of coercion in order to meet the definition of trafficking like you do for adults, because children cannot in any way consent to the sex or the sale of it. When we start thinking of trafficking that involves children that are considered residents of the United States proper, this is termed domestic minor sex trafficking. For this talk, I will fall back to human trafficking or trafficking. Just know that when I am using that term, I'm specifically talking about this less than 18 population. So how big of a problem is this? What's the data and the stats? Honestly, it's pretty hard to get a great idea of because it's been such an underground thing. It used to be very much equated with prostitution, which was a criminal activity, and people didn't want to talk about it, one, for the stigma, and two, for fear of prosecution or retaliation. We do know, however, a lot of estimates come from our homeless youth population and surveys and talking with them. So when we think worldwide, it's estimated there are victims in at least 152 countries across the world. And it could be up into the millions for the number of victims. So these are not the kids or adolescents that are at risk, but have been victims of this. Within the United States, it's estimated approximately 300,000 children are at risk, and that's going to equate to about 4 to 10% of all U.S. children already being trafficked. We do have pretty good survey data, again, from the homeless youth population or high school-based surveys. It seems to be more around this 4%. 10% could be a little bit on the higher estimate. So it seems like it's around 4% have already been trafficked through these surveys. There was a study that came out of Ohio, though. I'm not sure what their population exactly is. I'm not quite as familiar with that. But in their estimations, 30% of their youth had already been trafficked. We know, again, from this homeless youth population, at a minimum, about 30% of the homeless youth have participated in survival sex, which is trading sex to meet their basic needs, such as food, shelter, clean clothes. When we specifically look at surveys in the US and Canadian middle school and high school students, again, it's that 2 to 4% range that have already been trafficked and they traded a sexual favor for something of monetary value. So when we're talking about trafficking, who are the victims? So it can feel a lot like this, especially when you work in this field. It's the sea of people, and you need to try and figure out who's being trafficked. Because as you can imagine, the child or adolescent may not know they're being trafficked. They may not see anything wrong with it. Or if they do, they're not going to be very forthcoming with this information, again, because there is this stigma associated with it. So these next images, when you Google human sex trafficking and you add children in there, these are the first 5 images on Google that pop up. So it shows a child's hands in bondage, a girl with chains and handcuffs on, and it says she's not for sale. This child that appears to have been abducted and looks scared with a presumed male hand over her mouth so she cannot speak. And somebody who's been branded with this barcode, which brings up the stereotype of the traffic victim. Most people, when they think about the traffic victim, the things that come to mind immediately are females, drug addicts. They've been branded, whether it's through a tattoo or some type of scar or some type of jewelry. They won't have any identification or ID on them. They won't have any money on them, or they're going to have a lot of cash on them. They're usually seen as dirty, poorly dressed. They're afraid, they're injured, they're very meek. That's this typical stereotype. But when we specifically think about children and adolescents, most of the kids look like this. They look like every other child that isn't being trafficked. Most victims of trafficking in children and adolescents, they live with their parents and their guardians. They're going to school regularly. They don't have a load of cash. They don't always have physical injuries. Most of them do not have tattoos. They're appropriately dressed in clean, trendy clothes, and they're as cooperative as any other kid. So with that, it makes it really hard to know who's actually being trafficked. And then to complicate things a little bit more in this population, up to 30% of kids may not ever have a trafficker and they're trafficking themselves. Or we know around 8% are first trafficked by their parents or their caregiver. So that brings up the question of how are we going to know? Who are we going to know is being trafficked so that we can help them? Again, as you can imagine, the data is pretty limited. It's a topic that's just starting to come to light, and we're just starting to make more sense of it. But we know there's some key features or risk factors that are out there through this study of the homeless youth population and through surveys that have been done and data of children who have already been identified as victims, talking with them. So I think it's always nice to illustrate with some cases. So both of these cases that I'm going to present, I've actually had within the last 2 years and taken care of. So these are just a couple kids to kind of give you an idea of what are we dealing with. So this first case is a 14-year-old female. Police were on scene with her. A bystander called and they said, "I'm really worried about this girl. Can you come?" So when police are talking with her, they find out she ran away from her foster home a few days before. And this bystander had called at the local Quick Trip because this 14-year-old was arguing with an adult male that it appeared she did not seem to know. When she's talking with police, she discloses that for these last 3 days since she ran away, she's been couch surfing and she's been having sex with this male in order to have a place to stay and her marijuana. Police notice that she has circular bruises to her upper arms. She reports this is from being held down. They also note she has superficial cuts to her wrist bilaterally, and she says she does cut herself because it helps her relieve her anxiety. And at the time when police were meeting with her, she is reporting that she is acutely suicidal. So if you guys just want to type in the chat, or you could unmute yourself for this, whatever you're comfortable with, kind of what are the next steps, especially from an EMS perspective? Do you have any mandated reports? Kind of where do you go from here? I can't hear anyone, but I can check the chat after we're done sharing at the end. I think the obvious next step that's in everyone's mind is she needs to go be evaluated, right? She's reporting acute suicidality. She may or may not have a plan. We're not sure yet, but she needs more medical care and more assessment. So if she is willing, bring her into the nearest emergency department that can help identify and treat her. When we start thinking about mandated reports, she's identifying that she's been couch surfing and trading sex for a place to stay and drugs. That meets the definition for trafficking in children. Those mandated reports are to Child Protective Services, law enforcement or LE, and the FBI for human trafficking. And we'll talk a little bit more about reports later on and kind of the role and perspective when we think about you as EMS providers specifically. So this next case is a little bit different. This was a 14-year-old male that EMS was called to a residence for, and the call was for loss of vision and a fever. This 14-year-old male, he speaks Spanish only and is not able to converse with anyone on the ambulance crew at the time, and there was no apparent caregiver or anyone else home. It's noted right away that this adolescent's left eye is completely swollen shut, and there's dried blood that appears to be coming out. He overall appeared very unwell. He was brought into the pediatric emergency department appropriately for care. In the course of his treatment while there, an older male eventually arrives, and he calls himself this boy's uncle. It later comes to light this child is admitted, he gets a full workup. Throughout all of this, it turns out he had a very significant gonococcal eye infection from gonorrhea, and he later ended up disclosing in his hospitalization in sex and labor trafficking that he had been brought over from Guatemala, and within the process of being brought over, had been sexually and physically abused and was being forced to work in order to pay off some of his family's debt back in Guatemala. So this is just a different illustration of, again, a different form of trafficking in kids, not only sex trafficking, but this case also illustrated that piece of labor trafficking. So again, we can discuss this a little bit more at the end if anyone has thoughts or questions. So when we start thinking about trafficking, risk factors, especially in children, are a big deal. So what are the risk factors for human trafficking in adolescents and kids? Well, one of the biggest ones is age. Being a runaway, a homeless, or this thrown away youth. Thrown away youth, I think, is a term not everyone's familiar with, but that's the population where the family is kicking them out or throwing them away. So they're technically homeless, but they're the people who maybe do have a family, but the family just doesn't want them. A history of physical or sexual abuse or past neglect. Caregiver dysfunction, whether it's substance abuse, mental health issues, IPV, or intimate partner violence. Having high-risk sexual behaviors and putting themselves in potentially risky situations. Having a history of a juvenile justice system involvement or prior CPS involvement. We know our LGBTQ+ population is higher risk. Any children with mental health, substance abuse, developmental or learning delays or disabilities is also at higher risk. We know girls who are involved with gangs are higher risk to be trafficked. Overall, just living in an area with a higher criminal activity, or living in this area where there's this transit male population. So thinking truck stops, convention centers, military bases. I can tell you it's always a big topic of consideration for trafficking, whatever city the Super Bowl is going to be in, because we know whatever city the Super Bowl is happening, there is an uptick we see in victims of trafficking. So diving into these first 5 a little bit more and as to why are these actual risk factors. So for age, we know that youth or adolescents, they don't have a fully developed prefrontal cortex. This gives them issues with impulse control. It makes it where they can't critically analyze a situation and come up with an alternate. So it's really hard for them to truly get an idea of the risk and benefits and what else could I be doing. We know there's lots of hormones in this time, so they're learning about their own sexuality and they're adjusting to all of these hormones and physical changes. Adolescents have fewer coping mechanisms. They have these smaller support circles. They have this inherent need for acceptance and to feel fit and loved, which can make it very easy when you think about their lack of a prefrontal cortex, need for acceptance, for somebody to come in and potentially start grooming them into this life of being trafficked. As far as grooming goes, that is a lecture in and of itself. But very briefly, grooming is the process by which an adult gains a child's trust very slowly and starts to make them think that they love them or they're in a relationship. And by doing this, they're eventually able to coerce the child into doing sexual acts or other things that they would not have normally done. So the second risk factor was this runaway, homeless, thrown away youth. There was a really good study done by Green et al. And that showed that, again, around 30% of these homeless youth had participated in survival sex in order to meet their needs. When you look at this population specifically, a lot of them had a history of past child maltreatment that led to them being in this situation where they felt they needed to trade sex to meet their basic needs. This lack of resources and other means, as you can imagine, paves the way into that, because what adolescent or adult, for that matter, wants to be without a roof over their head or without food. So this history of child maltreatment, this may be one of the biggest risk factors we know for what causes children and adolescents to enter into trafficking. So when you look at the trafficked population, specifically these adolescents, up to 60% of them will have prior child physical or sexual abuse in their history. There was one study that was based out of Las Vegas, and when they looked at their homeless youth population, 70% of their trafficked youth had a history of child sexual abuse, compared to youth who are also homeless, but they were deemed at risk of trafficking. They had not yet been trafficked. There was only 11%. So you can see that huge, almost 60% difference in the ones that had this history of child maltreatment being trafficked. So when we start thinking now of caregiver dysfunction as far as a risk factor, we know within the adult population, poverty alone is one of the largest risk factors for an adult being trafficked. Again, in kids, we don't see that unless it's now being coupled with this very dysfunctional type of family. Then it's a bigger risk factor. So the caregiver dysfunction could be substance abuse, poorly or untreated mental health issues, exposure to domestic violence, or being exposed to promiscuity. One of the last risk factors we'll talk about is this high-risk sexual behavior. So having an early age of sexual debut, which is defined as 13 and a half for females or 12 and a half for males, a history of multiple sexually transmitted infections or STIs, and having multiple sexual partners. The idea behind this is they're just putting themselves in more risky situations, which makes them, again, more vulnerable to be trafficked. So why do the risk factors matter? Well, the biggest is for the outcomes. We know the outcomes can be linked to health, physical and mental, their safety, and their future. Excuse me. We also have really good literature in the ACEs, or these adverse childhood experiences. If you're not familiar with that, again, I would encourage you to look that up. But we know that the more bad things that happen, domestic violence, child maltreatment, having a parent that's incarcerated, the more things that add up in childhood can actually influence health later on, such as risk for diabetes, cancer, stroke, and even death. And one of the biggest reasons risk factors matter, especially in our adolescents population, is for prevention. If we know what places somebody at risk of this, how can we now intervene in those risk factors and try and prevent it? So moving on to these health outcomes. So we've identified these victims as being trafficked. What things do we need to be thinking about as far as taking care of them as medical providers? Well, mental health issues are rampant in this population. Unfortunately, around 90% of all adolescents at the time they're identified as a trafficked victim are acutely suicidal, and that needs to be addressed. There's going to be physical health issues. It could be a chronic health diagnosis that hasn't been managed and been neglected, such as diabetes and the diabetics going without insulin, severe eczema, not getting their creams or ointments and having significant infections. It could be asthma, not having their inhalers or the ability to breathe as comfortably as they would like. They also can have acute health issues, whether it's physical injuries. It could also be STIs or pregnancy. We know that most victims of trafficking, after they're identified, will go back to trafficking. Unfortunately, it is so hard to change the lifestyles or the things that life has thrown at these adolescents, for lack of better words, to change those factors and those effects in one moment. That's something that's going to take time. So even though we're able to identify them and help them in that acute moment, the chance of them going back to trafficking is pretty high. We know their risk of pregnancy is higher, and their sexually transmitted infection risk is also higher. So the medical care that's recommended when we identify somebody as being a victim is, one, they're a victim. So you've heard me say victim. I'm not saying prostitutes. I'm not saying criminals. So it's being very trauma informed and trying, excuse me, to break up that stigma. When you're working with these victims, again, you want to be very trauma informed. You want to get just the basics to do your job well. So who, what, where, and when. Those are the things that are going to help you figure out, where does this victim need to go? Do they need acute medical care? Could this be outpatient? In your who and when and where will help with all the mandated reports as to what county may it need to go to, what jurisdiction. Again, through this, you're going to be able to identify those acute medical needs that are going to require an urgent evaluation. Again, as far as trauma-informed care goes, if you're going to do an exam, ask for permission and honor that answer. So if you notice they have an injury on their arm, instead of just grabbing their arm and looking at it, ask for permission. These kids and adolescents have already had things taken away from them, so giving them their body back and their choice back. So may I look at your arm? And if the answer is no, you need to honor that and not look. If you truly need to see the injury, then you tell them with a statement, I am going to look at your arm, and you don't give them that choice if it's a must. But really trying to bring it back and victim-centered and giving them the choice will make it easier for them to cooperate with you. And at the end of it, just bringing them to definitive care. Usually that would be an emergency department setting. So for documentation purposes, when you're taking care of these victims, complete it as you would any other encounter. Make the mandated reports, whether that's Child Protective Services, CPS, LE or law enforcement, the FBI for trafficking cases. And usually with you guys, when you think of EMS, usually law enforcement's also on scene. So it really could just be a discussion with whoever is on scene and responding. Are they going to make the reports? Do they need you to do anything? That's something that can be really nice and helpful while you are there on scene. The patient might fear what's coming next and what's going to be documented, so you can always feel free to discuss confidentiality. Likely the information is going to be shared with police and CPS if they've told you something that's going to require a mandated report, and it's okay to tell them that. Something that has come up recently that I think it is important to address is letting them know that they can't remain anonymous when it becomes in news reports. We're going to have to release their name and their information, but again, making sure they know that they are going to be safe. We are going to try and prevent anything bad from happening to them. And as far as their physical exam findings, document as you would. Document it very well, and you can, on patient answers, put things in quotes. It's okay to use their words. So shifting gears a little now, that's kind of it for the victim side. But when we start thinking about trafficking, like I said, 30% of adolescents will not have a trafficker. But what about that other 70%? Who's doing the trafficking in those cases? So we know that not all trafficked kids are actually being controlled by this third party. There was a couple of studies that came out. There was one that was based out of a child advocacy center, or a CAC. This is a place where a multidisciplinary team, including county prosecutors, law enforcement, medical doctors, forensic interviewers, everyone comes together to support the child at one time. So the child only has to tell their story once. So in a study that was done at the CAC, up to a quarter of kids that were being evaluated there for trafficking were not being controlled by a third party. So a little bit bigger amount. Up to 60% of the homeless victims were saying they were trafficking themselves and they did not have a trafficker. And then there was another study, again, that was based out of another homeless youth population, and it was around 70% said, I did have a trafficker. So you can see there is a discrepancy in that number. We believe it's a minority of kids that will traffic themselves, but at some point, most kids will have a trafficker and or go on to traffic themselves later on. So if they're trafficking themselves, why? Well, the biggest reason is survival sex. Again, engaging in sex to meet their basic needs. A lot of this happens through the commercial sale of sex, through online solicitation, whether it's photos, meetups, sexual favors. A lot of the victims, when we talk about trafficking, actually live at home. So there is a study that came from kids who came in for a forensic medical evaluation. These are the evaluations with us as child abuse pediatricians, plus or minus DNA collection. So in the kids who came in for those type of evaluations, around half live with their mom, plus or minus their dad, at the time they were identified as a trafficked victim. Around 70% of them had lived with their parents at some point while being trafficked. So what does this say about the parents and caregivers? If we know a lot of these victims, they're staying, living, and presenting with these caregivers, well, the parents may or may not actually be aware of the trafficking, or they may or may not actually be complicit in assisting in the trafficking. It's estimated worldwide that over 40% of all trafficking of children and adolescents is actually starting with a parent. There was another study, again, out of the CAC, where 20% lived with their parents at the time they were first trafficked, with 8% of those kids having been trafficked by their parent. So that's a lot kind of about what is trafficking, what are our risk factors, what kind of medical care do the victims need, and who's trafficking. So kind of the bread and butter now is how do we, once we identify them, how do we help them? Well, one of the best things we can do is what we're doing today, raising awareness that this is a problem, putting out education and dispelling all this misinformation that we talked about with the stereotype. And one of the other big things we can do is screen. We know there's risk factors, and we actually have a really good screening tool we could use. We know youth are not likely to disclose to any healthcare provider. Again, fear, stigma, the concerns of criminal activity, they're not just going to self-identify. But with these risk factors, we do have a screening tool that we could use. So this is a screening tool that was developed by Dr. Jordan Greenbaum and her team. I use this all the time in Kansas City. The first 6 questions specifically are related to risk factors. So if you answer yes to 2 or more of those, you're considered at risk for trafficking. Questions 7 through 9 are specifically asking about the sale of sex for something of a monetary value or trading photos, dancing. If you answer yes, I've done that, and yes, I had to do it, that already constitutes that this child's been trafficked. And then question 10 is directly the definition of trafficking. So if someone were to answer yes to that, again, they've already been trafficked. So now kind of to end things before we open it up to questions and discussion, what are the resources? Some of the best resources are going to be your local child advocacy center or CAC, or if you're associated with a hospital or clinic, if there's a child abuse or child protection team, that can be a wonderful resource. Your local child protection services or CPS and law enforcement, also including local FBI agencies. There's a National Human Trafficking Resource Center hotline, which I'll bring up here in a second. There's also a Polaris project, which offers different funding, places to stay, support services for victims, as does Shared Hope International, and then this National Center for Missing and Exploited Youth. One really cool program we have in Minnesota, I'm sure other states have it, but I'm familiar with our state right now, is called Safe Harbor. And what Safe Harbor is, there's victim advocates, police officers, attorneys, a whole team of people that come behind and will meet the victim who's been trafficked wherever they are. If that's at the gas station, like this 14-year-old girl had been identified, if it's in the ER, if it's at a clinic appointment, and they will walk them through every process and be there. They can help assist with jobs, housing, schooling. They'll be them if there's going to be charges or a court process for whoever the perpetrator or the trafficker was. They help with mental health, medical care, etc. It is a really, really beautiful program. And again, this National Center for Missing and Exploited Children, the website's there. It is a wonderful, wonderful website that walks you through different numbers and reporting. They have webinars, etc. It's a really awesome resource. So with that, thank you guys so much for your time and attention. I am going to stop sharing here so I can see everyone and open it up for questions or discussion. Reading through the chat here. So yes, looks like mandated reporting, going back to the cases. Wonderful. Anybody else with thoughts, questions, things I can explain further, better? Well, wonderful. Then you guys might get a little bit of time back in your day.
We have a question here from Lucia. Is it ever going to be mandated for EMS to take courses on human trafficking as nurses have, or as nurses have too soon?
I think that's an interesting question, and I'm not familiar enough with the legislation as far as EMS providers go. I can tell you there's a big push through ASAP, or the American College of Emergency Physicians, that all emergency physicians need to be educated and undergo some type of training with this. And there's also getting to be a push from the AAP, or the American Academy of Pediatrics, for all providers. So I think eventually, as with anything in medicine, I feel like there's always kind of this stream down effect. If you ask me my personal opinion, I would say, heck yes, because you guys are on the front line. You're the one interacting with all kinds of patients and people that may or may not come in to see us as medical providers. But as far as will it be mandated, I don't know. Anybody else? All right. Well, if you guys have any questions, I will put my email here in the chat. Feel free to email me if you think of anything comes up, or just questions at all.
Thank you, Cree, for an engaging and informative session. The slides for today's session were included in the reminder email that you received 1 hour in advance from the Zoom. The slides and the session recording will be posted to the AAA website within 48 hours and will also be emailed out in the next AAA member digest. We hope to see you on another American Ambulance Association webinar soon. Thank you very much and have a great day.